The next session is Workshop 10, Radiotherapy, Imaging and Diagnosis, irAE. The chairs are Dr. A. Kadir Dokmechi, Dr. Teiji Kuzuya, Dr. Shuichiro Shina, and Dr. Ryosuke Tateishi. Doctors, please.
Let's start with the last session, Workshop 10, Radiotherapy, Imaging and Diagnosis, and irAE. So the first speaker is the Dr. Kawaoka from Hiroshima University. The title of his talk is Effectiveness of Repeated Stereotactics Body Radiation Therapy for Hepatocellular Carcinoma. Would you start, please, your presentation?
Thank you, Dr. Kuzuya. I will talk about SBRT. SBRT can be performed even for patients for whom surgery or RFA is unsuitable due to age complication. The target lesion is close to vessels, bile ducts, or the diaphragm, or difficulty because the lesion cannot be visualized by ultrasound. On the other hand, the recurrence of FCC after surgery and RFA has been reported to reach 80% at 5 years. And few reports have described the use of repeated SBRT as a treatment for recurrence. In addition, many issues remain unknown regarding changes in liver function and side effects after repeated SBRT. In this report, we retrospectively evaluated not only local tumor control and survival following SBRT for SCC, but also those for repeated SBRT. Among the cases in which test SBRT was performed at our hospital, and it has been more than 6 months, we conducted a study on 220 patients who met the following 5 criteria. 1, PS0-1, 2, number of tumors, 1 to 3, 3 cases in which surgery or local treatment is difficult. 4, child score of 7 points or less, and 5, tumor diameter of 5 centimeters or less. The cases in which irradiation was performed multiple times included 53 patients who received 2 irradiations, 10 patients who received 3 irradiation, 4 patients who received 4 irradiation, and 1 patient who received 5 irradiations. Patient background of the total 2020 cases. The median age was 76 years. The male to female ratio was 143:77. And the most common liver background was HCV. Regarding liver reserve, child grade A amounted for the 197 cases, amounting for the 90% of the total. The median tumor diameter was 16 millimeters, and the number of the tumors was 201 single cases, and 87% of the 191 cases treated with TSE. There were 48 cases in which SBRT was performed for newly diagnosed SCC, but most cases were irradiated for recurrence cases. Regarding the first irradiation of multiple repeated cases, 50 out of the 53 cases had child grade A, and 46 cases repeated test combination. Until around 2014, our hospital has been using iCenter prescription, which is a method prescribing based on the dose received by the center of the tumor. We started the protocol divided into the central 60 gray and peripheral 48 gray. Since 2014, there has been a change to PTV, the 95% per prescription, which is a method of prescribing based on the radiation dose received by the center tumor, which amount for the more than first half of the cases during the target period. Regarding the overall survival, overall median survival time was 52 months, and the 3 years survival rate and 5 years survival rate 65 and 45 respectively. The median survival time from the first irradiation for repeated patient was 76 months, and 3 years survival rate and 5 years survival rate was 78 and 61 respectively. Regarding disease-free survival and overall median was 17 months. For cases treated with repeated, the median times was 13 months. Local recurrence occurred in 6 cases out of the 220 cases, and the 5-year recurrence rate was 3.4%. 4 of the 6 patients had multiple intrahepatic recurrence, including local recurrences. Regarding the cases in which repeated were performed, only 1 case had local recurrence at the site after the second irradiation, and the mode of recurrence was multiple intrahepatic recurrence, including locally. Next, in order to examine whether there are changes in treatment efficacy, reserve or site effect depending on the irradiated area among cases that have been irradiated multiple times. We will classify and compare whether the lesion target for irradiation are in the same area or in separate area. Here is a background comparison of 13 cases in same area and 40 cases in remote area. Regarding the irradiation reserve capacity, there was no significant difference in child classification or RB score, not were there significant difference in other factors. PEN-OS was compared between cases in the same area and irradiated and cases in which remote segments were irradiated. The median survival times were 92 months and 70 months, with no significant difference between the 2 groups. Among patients who received multiple irradiations, changes in reserve capacity during the 12 months after the last irradiation and compared using RB score every 3 months. In both cases, a significant increase in RB score was observed between 6 and 12 months after the irradiation, but there was significant increase in RB score before irradiation. 3 months, 6 months, and 12 months after irradiation, I don't notice any difference. Overall, as for adverse events after SBRT, according to CTCA version 5, there were one cases each of the grade 3 bile duct stenosis and portal vein thrombosis, but no grade 4 were related to death. Among the cases in which multiple irradiation were performed, one case of grade 3 bile duct structure was observed in the case in which the same area and irradiated, and no grade 3 adverse event were observed in the case in which separated area were irradiated. This is the conclusion. The local control ability and safety of test SBRT for SCC were good. Even in case of repeated, and the therapeutic effect was found to be independent of the area targeted for irradiation. Thank you for your attention.
Thank you for your good presentation. So do you have any comments or questions from the audience? Please.
Good afternoon. I'm Dr. Cha Yong-rim from Seoul, Korea University. I'm also a radiation oncologist. I have two questions. The first one is about what kind of method do you use for the targeting the respiratory motion? And the second one is, do you think we have a necessity to use proton or carbon therapy for that kind of small HCC rather than SBRT?
We decided the target by CT. We described the area beside. One more question.
Sorry, the first question is because the liver move with the respiration, there are several methods to control the respiratory motion, such as you can stop breathing, or you can follow the motion of the belly. So I just want to know what method do you use? So.
We stop the
stop breathing.
breath. Radiation is performed.
Doesn't patient feel uncomfortable for the stop breathing during the therapy? Because they need to stop breathe for 2 or 3 minutes. I don't know, about 1 or 2 minutes.
Time? What time? How long?
Yeah.
息止めが苦しいんじゃないかって。
少し、ごめんなさい。
Short
time.
Short stop and respiration stop. Okay. And second one is, do you think there is? Do you think we need to move to the proton or carbon, or do you think SBRT is enough for early HCC treatment?
Carbon.
Yeah, actually, carbon or proton therapy is not covered by health insurance when the tumor is small in size. Okay. So we prefer to use SBRT instead of particle therapy.
Thank you.
I'd like to suggest two types of bias. One is selection bias, because that some patients might not receive repeated radiation therapy because of poor liver function after the primary radiation therapy. Those patients are not included in the study, right?
バイアスが
肝機能が落ちている人は 次の治療を受けられない人は入らないじゃないですか。
はい。そう
Understand?
ですね。はい。
The other important bias is, as I mentioned in the previous presentation, the immortal time bias, because that, in repeated cases, the survival between the primary radiation to the secondary or tertiary radiation is guaranteed. So as you presented in your slide, the median survival time is longer in repeated case. It's indicated that kind of that is indicated the presence of immortal time bias. So you need to stratify the patient according to the time of the radiation and stratify the patient based on the time of the radiation, and the start time should be the secondary or tertiary irradiation to the follow-up period, the end of the follow-up period.
Okay. I will try to study in future. Thank you.
Thank you, Dr. Kaoka. Thank you. So next presenter is the Dr. Abe from Iwate Medical University. The title of her talk is Establishment of Hepatic Tumor Differentiation and Hepatocellular Carcinoma Grading Method by Quantitative Analysis of Contrast-Enhanced Ultrasound Images using Microbubbles. Please, Judge.
Thank you for introduction. There is no COI in our study. The pathogenesis of HCC and other liver tumor is very closely related to blood flow. Evaluation of tumor blood flow and vascular morphology is important in clinical oncology, not only for differential diagnosis, but also for histological differentiation as a marker of malignancy, prediction of therapeutic response, and monitoring. With recent innovations in imaging technology and diagnostic methods, diagnostic information on liver tumor blood flow obtained by ultrasonography has changed significantly, and more objective and quantitative diagnostic methods are required. Contrast vector imaging, CVI, is a new application in Canon Apereo I3s. In conventional contrast-enhanced ultrasonography, we often use the sensory term such as quickly or slowly, which lacks objectivity. However, CVI can track, record, analyze the trajectory of contrast-enhanced agent bubbles with tracking them with high flame rate CTI technology. By tracking a single bubble continuously, CVI can analyze tumor blood flow more accurately than ever. A variety of parameters are available as shown in the slide. So in this study, we examined the usefulness of CUS with Sonazoid and blood flow analysis of liver tumor by CVI for differential diagnosis of liver tumors and diagnosis of the grade of HCC. This slide shows the study's flowchart. Eligible nodules and patients were 232 of 278 who underwent CUS and CVI from June 2019 to December 2021. Median tumor diameter was 2.5 and median tumor depth was 6.5 centimeters. There were 7 kinds of hepatic tumors, including 158 HCC patients. We used Canon Apereo I800 and PBT475BX probe. In all cases, we fixed the imaging conditions as shown in the slide. And we measured bubble density in our ratio and bubble density. We measured bubble velocity and in L ratio and bubble density. This slide shows the Sonazoid CUS and CBI protocol. 1 minute after of Sonazoid bolus shot, CBI analysis was performed until post-vascular phase in 10 minutes. We measured these 3 parameters. 1, velocity. This is mean the speed of the bubble. 2, in R ratio, which means the direction of the bubble, with centrifugal displayed in red and centrifugal in blue. And 3, bubble density. CBI can visualize bubble density in color. From this slide, we will show the result of this study. First of all, there was no significant difference between the velocity. Some HCC cases, there were some case lower velocity than hemangioma, as shown in this slide. Next, in out ratio, FNH was significant lower than the other tumors, which mean the nuclear vessels from radially from the center of the outside, like this figure. And last, bubble density. There was no significant differences between tumors. We also compared CBI velocity by HCC CD type. We used CD classification into 4 types, labeled by Kawamura et al. CBI velocity was increased as the CD type increased. So CD type 4, the velocity was most higher. Also, bubble density showed this result. As the CD type rates, bubble density decreased. On the other hand, in out ratio, there was no differences. We also compared the CBI parameter by histological differentials for 40 HCC patients who underwent the liver biopsy. As shown in this figure, velocity was increased. The well differentiation shows 16.8 and moderately differentiation 20.6 and fully differentiation 32.3. On the other hand, bubble density showed decreasing. The usefulness of CBI in quantitative diagnosis of liver tumors and grading of HCC has been demonstrated. Quantitative assessment of fine blood flow in liver tumors using CBI has the potential to improve the objectivity of CUS. Thank you for your attention.
Thank you for your good research and the beautiful images. So, do you have any questions or comments from the audience?
Thank you for your beautiful presentation. I have one question. I'd like to clarify what the bubble density means. You check the bubble density during the 60 minutes after the injection of contrast media, just after 6 minutes. So you can, you can observe the fast enhancement in probably 15 to 20 minutes, right? After the injection.
Sorry, pardon.
After the sonazoid injection, you may observe the fast, vascular phase.
Injection,
15 to 20 minutes, 20 seconds after the ablation, after the injection. So, the velocity also matters, and we need to discuss the permeability of the tumor. Permeability depends on the histological feature of HCC, like thick trabecular and or more benign feature, or sometimes fibrosis in the tumor. So your study suggests that in poorly differentiated CC, bubble density is lower compared to moderate or well differentiated CC. What suggests that?
Thank you for your question. Maybe Dr. Tade's point is very important and good question. If we analyze the CBI after 15 minutes or 20 minutes, bubble density was maybe more higher because continuous injection in the minute.
You mean that, right, the 20 minutes or 20 seconds?
20 seconds,
Seconds,
sorry.
Yeah, right.
Actually, I have not conclusion not yet about that, because before this study, I thought the bubble density was higher in poorly differentiation, I thought, but the result was
Opposite.
Yeah, opposite.
Yeah.
So we have to the discussion about that.
Maybe the velocity depends on the diameter of the vessel, artery, feeding artery, also the resistance of the blood flow caused by the tumor itself. So there might be a complicated relationship between the velocity and permeability and the bubble density.
Yeah,
so
okay.
I ask you to clarify these things later.
Okay, thank you.
Yeah, please.
Thank you for the beautiful data. I'm Jun Arai from Aichi Medical University. One of the hot topics is whether the hypovascular nodules would be progressed into the actual HCC or not. So would it be possible to predict whether a small nodule can be progressed into the HCC with CVI?
Thank you for the question. I don't know, not yet, but maybe there is a possibility of your question. So I want to take the more patient of historical differentiation and just check the CBI.
Yeah.
So maybe I can tell you more good result in the future.
Yeah. And among your participants, among
Yeah.
the HCC, so have you already compared the differentiation, purely differentiated or the middle differentiated or differentiation? No?
Not yet.
Yes, thank you.
Thank you.
So can I ask you a question?
Yeah.
So you showed us very beautiful images. So the tumor site is located in very near from the liver surface. So please tell me what case is limited by the CBI?
Okay, thank you. Limitation is more deeply allocation, so because in CUS with sonozoid, we can't catch the sonozoid bubble in the deepest tumor location. So it's a one of the limitation,
Oh, how about the examiner's experience or skills?
Maybe the location with segmental 7 or 8 near IBC.
My question is the examiner's skill or experience.
Examining or skill. Examining skill.
うまい下手があるでしょう。
ですね。
Technique.
I don't know.
Technique always matters. Yeah, of course.
But yeah, in this study, the over 5 and over 10 years experienced ecologists was performed. Maybe there was no difference between two to ecologists, maybe.
Thank you. Yeah. Thank you, Dr. Abe. Yeah.
Thank you.
So we are a little bit delayed. So the third speaker is Ryo Izai of Chiba University. He will talk about differentiation of AST-ALT elevation during immunotherapy in patients with advanced hepatocellular carcinoma and other cancers. Please.
Thank you for introduction. I will start presentation. COI is as shown in the slide. After the approval of immune checkpoint inhibitors such as atezolizumab plus bevacizumab, STRIDE regimen, and durvalumab alone, the management of liver injury due to immune-related adverse event has become important in the systemic therapy of hepatocellular carcinoma. irAE hepatitis is a frequent and highly lethal condition. For INBRAVE 150, SDLT elevations of grade 3 or higher are 7% and 3.6%, but there is variation among reports. With regard to LT elevation, there are reports that it is more frequent with the use of anti-CTLA-4 antibody. With the advent of ICIs, the management of irAE has become increasingly important in the systemic therapy for HCC. However, systemic therapy for HCC may also cause liver injury other than irAE, making it difficult to distinguish them from irAE in many cases. We studied on ICI-treated cohorts of HCC and other cancer to characterize the ST-LT elevations observed during the treatment for HCC with atezolizumab plus bevacizumab. The patient and methods are as follows. ST-LT elevation were collected retrospectively, and we analyzed for patterns and causes of elevation and risk factors. Demographic and baseline characteristics are shown in the table. In the HCC cohort, 165 patients who received atezolizumab plus bevacizumab for unresectable HCC were selected for analysis. The median age was 74 years, about 84% were male. The most common etiology was non-BNOZ. Macroscopic vascular invasion and extrahepatic spread were around 30%. In the other cancer cohort, among 801 patients who received ICI, 699 patients who received anti-PD-1, PD-L1 antibody monotherapy or combination therapy with anti-PD-1 and anti-CTLA-4 antibody were selected for analysis. Lung cancer was the most common in the other cancer cohort. The frequency of ST-LT elevation for all grades was 57.6% in the HCC cohort. In other cancers cohort, it was 39.8% in patients treated with anti-PD-1, PD-L1 antibody alone, and 45.3% in patients treated with anti-PD-1 and anti-CTLA-4 antibody. ST-LT elevations of grade 2 or higher were 13.3% in the HCC cohort and 8.5% and 20.8% in the other cancer cohort. We focused on ST-LT elevations of grade 2 or higher because it is not possible to differentiate the cause of ST-LT elevation of grade 1. Regarding the differentiation of ST-LT elevation, small necrosis, biliary tract disorder, shock liver, and drug-induced damage due to other drugs were excluded, and we diagnosed irAE hepatitis. STLT elevation of grade 2 or higher with a diagnosis of irAE hepatitis was 13.5% in the HCC cohort and 34.5% and 63.6% in the other cancer cohort. The frequency of irAE hepatitis was higher with regimen that included anti-CTLA-4 antibody. Incidence of irAE for the denominator of each cohort is as follows. In the HCC cohort, looking at case other than irAE, ST-LT elevations due to tumor necrosis, increase, and biliary tract disorder were more frequent. In the HCC cohort, intrahepatic tumor-related ST-LT elevations were highly prevalent. The following is a breaking down of the treatment of irAE hepatitis. The prednisolone induction rate was 4.5% in the HCC cohort and 27.3% and 46.4% in other cancer cohort. In the HCC cohort, only one case required corticosteroid. We indicate cumulative incidence of ST-LT elevations of grade 2 or higher. In the HCC cohort, we compared by intrahepatic tumor volume. Higher intrahepatic tumor volume was associated with significantly higher cumulative incidence. In the other cancer cohort, we compared by the presence or absence of intrahepatic tumor. Cumulative incidence of ST-LT elevation are higher in the group with intrahepatic tumor. In a comparison by regimen, anti-PD-1 and anti-CTLA-4 antibody group had a significantly higher cumulative incidence of ST-LT elevation. ST-LT elevation of grade 2 or higher were observed at a higher rate in the groups with high intrahepatic tumor volume and in the group with concomitant and anti-CTLA-4 antibody. Here is a summary. Although ST-LT elevation was frequently observed in the HCC cohort, the number of cases diagnosed as irAE was limited, and only one case required corticosteroids. In both HCC and the other cancer cohort, ST-LT elevations of grade 2 or higher were more frequent in patients with large intrahepatic tumor volume, suggesting that these may be tumor-related ST-LT elevations. In the other cancer cohort, ST-LT elevations of grade 2 or higher were more frequent in patients with concomitant use of anti-CTLA-4 antibody. Here is the conclusion. To distinguish intrahepatic tumor-related ST-LT elevations is important for the diagnosis of irAE hepatitis, especially in HCC patients. With the advent of anti-CTLA-4 antibody combination regimens, the incidence of irAE hepatitis is expected to increase more frequently in the systemic therapy of HCC. Thank you for your attention.
Thank you very much. Are there any opinions or questions?
Omata, in this meeting, we presented 675 cases treated by this IO. The key issue is when there is an elevation of ALTs, whether you stop the treatment or not. And in fact, in our cases, when we stop the treatment, the prognosis is not that great. So in your definition, whatever the ALT levels, but the key question is how to stop it or not, because that may end up with a poor prognosis. So that's a key issue.
Thank you for the question.
And then maybe, ALTs, if you elevate only 100, if you claim that's a liver injury, then you have to stop on all the cases. So I think that's the producing a lot of problem in the hospitals because they don't consult us and then just seeing the elevation and stop it. So that's a little bit a problem for us. They don't come to us. They don't come to the hepatologist. And they just mention irAE, liver toxic, just simply seeing elevation LT, but no prothrombin time prolongation or no cholestasis. ということです。お願いします。肝障害だっつって肺がんも全部ねみんな薬止めちゃってるんですよ、はい、そうするとそれ予後悪いのだけどそれをちゃんとヘパトロジストにやればリバーファンクションにならないっていうぐらいのエレベーションはあんまり大騒ぎにするなと言ってるんです我々の病院ではだからこれもエレベーションがあったけどそれを薬を止めちゃって患者の予後を悪くしちゃダメですよということはないかって聞いてるわけ
ありがとうございます、Thank you、
ビリムバブは複数回投与されてるんですよね、他のがんだと。
Yes.
So you need to consider the cessation of CTLA4 inhibitor in case with treated with in case with lung cancer, because in liver cancer CTLA4 is administered only once. So you could not stop the administration of CTLA4.
We see that 1 ml per kilogram when sorry.
So you may discuss this matter with Professor Omata later. I recommend.
Second question.
Rechallenge. We initiate steroid. When a smooth taper is achieved, we also consider a challenge with ICA.
Okay. So,
excuse me. I'm Kazuhiko Kobayashi from Chiba University, one of co-workers of the presented. About the other cancer cohort, this is a retrospective study, so we just check the electronic chart and correct the data. So whether for the other cancers, the treatment has been stopped or not, we couldn't decide. And just from now, just the treatment doctors on each department of our hospital decided. And so from now on, that we became keep in touch to the irAE on hepatitis. So from now on, we make the decision. We are possible to make decision to stop or continue the chemotherapy for the other cancers. I'm sorry.
For the future's sake, I think I'm saying, you are really carefully studying what's the pathogenesis of the elevation. But as a clinicians, not simply seeing the elevation of ALT doesn't mean much, like prothrombin elongation or like bilirubin going up when the GOT and GPT declines. So those experiences with the hepatologists should be utilized in your hospital. So that's not just for your department, but for other part of the Chiba University hospitals that may help. That's my suggestion, depending upon your studies.
Thank you.
Okay, thank you very much for your very impressive talk. I'm Jalupong Sangwunmi from Thailand. So I just wonder that have you ever compare the hepatitis between HCC that receive the immunotherapy and the other therapeutic modalities? Are there any significant rate difference between each modalities? I mean, like, even though it is statistically significant different, like in the immunotherapy may increase the AST/ALT, but for the clinical presentation of the patient, do they have any clinically significant?
Sorry, I can't hear.
Have you ever compared with the other kind of treatment in HCC in your center? I mean, for the hepatitis, let's say like the group that they received immunotherapy and the group that they received the other kind of treatment.
Again, sorry, Kazumi Kobayashi from Chiba University. In this study, the cohort of HCC, all patients received atezolizumab plus bevacizumab for the first line. So we didn't check, for example, the patient with HCC treated by TKI, or in the future we try to collect data about durvalumab plus tremelimumab. So we didn't compare the treatment for HCC. I'm sorry.
Okay, so because this is related to the first question, because I also think that is, even though it is increases, but is it significant enough to stop the treatment of ICI or not? And the other thing that, because you conclude that for the increasing of AST/ALT, this might be related to the anti-CTLA-4. So that my question is that, do you have any expectation or speculation why anti-CTLA-4 may be related to the increases of the liver enzyme?
That's a really important but difficult to answer question.
Yeah, so, yeah, I understand.
Yeah, sorry, we don't have answers for your question. I'm sorry.
Yeah, thank you very much.
I'm sorry.
So I'd like to move on to the next speaker, Dr. Mio Tsuruoka from Tohoku University. The title of her presentation is the current status of IMH in our hospital and experience with the use of tacrolimus in case resistant to PSL and MFF.
Thank you, Chairman. My presentation is about IMH as irAE. We have no COI. First, liver dysfunction as an immune-related adverse event is sometimes referred to as ICI-induced immune-mediated hepatotoxicity, in short, IMH. In recent years, the treatment depends on the grade of hepatotoxicity. For cases with PSL resistance, both US and Japanese guidelines only recommend the use of mycophenolate with mofetil, MMF. No clear effective strategies have been established for dealing with PSL resistance cases. Therefore, we must consider carefully how to deal with PSL resistance cases. Our purpose is to report on the use of ACI and the occurrence of IMH in our hospital and its treatment methods, as well as to make suggestions on how to deal with refractory cases of PSL resistance. We investigated the clinical characteristics and treatment methods of 22 patients with grade 3 or 4 out of 108 patients with IMH out of 453 patients treated with ICI from November 2021 to October 2022 in all departments at our hospital. Treatment with tacrolimus was started in 2 cases with PSL and MMF resistance. In this study, We considered IMH as liver injury that occurred for the first time during the period of ICI treatment, including cases treated with other drugs. This is the percentage of ICI in all 453 patients. Nivolumab and pembrolizumab accounted for 33%, followed by atezolizumab at 14%. Nivolumab plus ipilimumab were counted separately from nivolumab alone in this study because both were ICIs and it was difficult to identify which was the cause of IMH. The following percentage of IMH by grade for each ICI. Green is the total number of patients per ICI, and from left to right, grade 1 to 2, 3 to 4, and the percentage of total is the number at the top of the graph. As previously reported that CTLA-4 inhibitors are prone to liver damage, the occurrence of IMH was notable in the ipilimumab and nivolumab regimen, with 45.3% of all grade and 70% of grade 3 or higher. Of all ICI treated patients, 18% have grade 1 to 2 IMH and 5% had grade 3 or higher. Patient background and clinical data for grade 3 and 4 for each ICI treatment. Although details analyzed was difficult due to the small number of patients, there does not seem to be significant differences. Next is the response of IMH patients with grade 3 or higher in each ICI. Grade 3 and 4 were 4.9% in 22 cases out of all ICI treatment cases. And 68.2% of the 15 cases out of those 22 cases were referred to our department. Overall, 3 cases improved without medication, 3 cases only with UDCA or NMMC, 14 cases with PSL. No cases improved with MMF and PSL only. And 2 cases were introduced with TAC. I would like to present these 2 cases. Case 1 is a 29-year-old male with lung cancer. His medical history is as shown below. 7 weeks after starting chemoradiotherapy, he changed his regimen to durvalumab. 2 weeks later, he was admitted to his main department with liver damage. The patient's laboratory result at the initial examination are shown here. The following is a clinical course chart. On the day of admission, the patient was treated with steroid pulse, 100 milligram for 2 days. The patient temporarily improved and was switched to oral medication, but MMF 100 milligram was introduced on the 7th day after a re-elevation of transaminases was observed. ALT decreased for a moment, but then rose again. Based on the result of the liver biopsy, TAC was introduced on the 24th days. Thereafter, the transaminases decreased steadily, and no relapse was observed, even though the patient finished taking the medication as an outpatient. So case 2 is a 59-year-old female with malignant melanoma. 2 weeks after starting treatment with ipilimumab plus nivolumab at the Department of Oncology of our hospital, she presented to our department because of the liver dysfunction as shown in figure. PSL was started on the day of admission, but there was no improvement. On the 18th day, a pulse was administered again, but the effect was not enough. On the 24th day, MMF was started, but the patient continued to get worse. So tacrolimus was started on the following day. After discharge from the hospital, tacrolimus and PSL was tapered off, but there was no relapse. After a discontinuation of medication, the patient becomes PSG. Liver biopsy pathology findings. In case 1, there was marked interface hepatitis as shown here, and the CD8 positive cells were visible. CD12 was negative. Although immunostaining was not performed in case 2, TAC was introduced as in case 1 because of the marked inflammatory cell infiltration and the ineffective cause of PSL and MMF. Discussions. ICIs have an anti-tumor effect due to T cell activation by blocking CTLA4 and PD-1, PD-L1. But about 8% develop IMH due to loss of immune tolerance. Histopathological findings of IMH include lobular acute hepatitis with eosinophilic cells, CD3 plus and CD8 positive lymphocytic infiltratis, and lobular central necrosis in previous reports. IMH with PSL resistance has been reported in several cases, and the use of MMFs, which suppress immunity by inhibiting lymphocyte DNA synthesis, is being considered. TAC appeared to be effective in inhibiting T cells differentiation and activation through a pathway distinct from that of MMF by binding to calcineurin in T cells. And indeed, histopathology confirmed T cell infiltration in our cases. Conclusions. We investigated the incidence and management of IMH in patients treated with ICI at our hospital. We would like to suggest that TAC may be an effective option for refractory PSL and MMF resistance cases. That's all for my presentation. Thank you.
Thank you for your presentation. Now this paper is open for discussion.
Again, this address the same issues because just elevation transaminase is not really the matter, because whether you're losing the patient by stopping the treatment or losing the patient with acute liver failure, so that's the question. So in this particular case also, there is no elevation of total bilirubin, and even you did the liver biopsies because the prothrombin time totally normal. So I mean, we have experienced so many cases acute hepatitis, and we're wondering whether you can reach to the 2000 GOT or GPT, but we don't worry about that. So why you are worrying so much about just a simple elevation of transaminases? 立石先生。
私答えるんですね。So I think
this is a matter of experience of a hepatologist.
I agree with you, but the duration of the elevation of AST/ALT may matter. So sometimes the duration exceed 1 month or 2 months. Maybe we also hepatologists worried about the result of.
So I understand that non-hepatologists worry so much about elevations if you reach, say, 1,000, but we have went through so many experiences, so many patients having elevations, so that's the thing.
Yeah, actually, in viral hepatitis, the viral is suppressed by the immune reaction. But in case of irAE, I don't know, but immune reactivation, continue without any kind of treatment.
Sorry about. In fact, in this meeting, there is a cases, cholestatic cases. That's a specific group of the patients. Cholangitis is actually produced, but simply elevation LT, we better look at carefully that maybe without any significant immunosuppressive treatment may go down. We don't know, but
yes. I agree with you. Is there any comments or questions from, please?
My name is Jun Arai from Aichi Medical University. Thank you for your beautiful data. So I have sometimes occurred this kind of problem, IMH. So we sometimes steroided MMF, but I have never used the tacrolimus. So I've just asked, which point are you thinking about restart the regimen? So just after stopping the tacrolimus, or the 10 milligram or small portion of dosage of tacrolimus, are you thinking about restarting the same regimen after the IMH? So in general, in terms of the steroid, generally less than 10 milligram per day steroid, we can sometimes restart the same regimen after recovering from the IMH. So of course it depends on the grading of the IMH.
Those patients show the grade 3.
So so it depends on the participant that generally not will change another regimen. So I'm just asking all of the patients did not restart the same regimen in your cohort with using tacrolimus?
Thank you for your question. So you mean why we choose tacrolimus for this case?
No. So sometimes after, in terms of the prednisone using patients, after recovering from the IMH, and the dosage of steroid will be reduced to 10 milligram per day and so forth, we can restart the same regimen. So are there any patients restarted the same regimen after recovering from IMH, after stopping tacrolimus? No?
There is only 2 cases, but so you can remember whether the clinician restarted, rechallenged the ICI after the stoppage of tacrolimus.
ICI restart.
ICI,
Case. Thank you for your question. Case 1 is became BSC. So not
How about case 2?
Never use ICI or chemotherapy. And
how about case 2?
Case 2, same as so so never.
So because the number of cases is too small to answer your question.
Okay, thank you.
Thank you.
So I'd like to move on to the last speaker for this session, and also a last speaker in this symposium, in this convention. I'm very honored to introduce Dr. Ashina, my mentor, from Juntendo University. He will be talking about the current status of tumor ablation in Japan and establishment of Japan Academy of Tumor Ablation, JATA.
Thank you. So ablation has been performed mainly for malignant liver tumors in Japan. In the field of liver tumors, ablation has developed through the competition with surgery. Since the ethanol injection period, we have had strong argument regarding which treatment is superior for HCC, surgical resection or percutaneous ablation. In Japan, we conducted a multi-center randomized control trial, SURF trial, to compare surgery with radiofrequency ablation. A total of 49 major centers in Japan enrolled patients with good hepatic function and HCC of 3 or fewer tumors, each 3 centimeters or less in diameter, during the 6-year period of 2009 to 2015. The 308 registered patients were followed for at least 5 years. And this is the final results of the SURF trial. So the SURF trial revealed that overall survival and recurrence-free survival were not significantly different between surgery and radiofrequency ablation in HCC of relatively early stage. So this was the old Japanese clinical practice guideline for HCC. So both surgical resection and radiofrequency ablation were treatment of choices for 3 or fewer tumors, each 3 centimeters less in diameter. However, resection was placed above radiofrequency ablation, indicating that resection should be a priority. As a result of SAF trial and other comparative studies, the revised algorithm in 2021 treats hepatic resection and ablation equally for patients with HCC who have 3 or fewer tumors, each 3 centimeters or less in diameter. This is a comparison of scars between surgical resection and ablation. Ablation is a minimally invasive therapy which does not require general anesthesia or laparotomy. So ablation is performed on patients with advanced liver cirrhosis or advanced age. So how about ablation for HCC of more than 3 tumors or over 3 centimeters in diameter? Actually, this 3 centimeter rule was proposed in 1980s, the era of ethanol injection. That is the criteria for 40 years ago, it's used even now. During those 40 years, ablation has evolved from percutaneous ethanol injection to first generation microwave ablation, radiofrequency ablation, and now new generation microwave ablation. So we now use new generation microwave ablation for large tumors. New generation microwave ablation system incorporating antenna cooling and high power generation has attracted attention. That new generation microwave ablation is technically similar to that of radiofrequency ablation. Under ultrasound guidance, we insert applicator into the tumor, and the microwave will produce heat, and the gas bubble produced by heat will cover the entire tumors. Okay. And I would like to show a demonstrable case. This is a 80-year-old man who was found to have a 4 centimeter HCC beneath the diaphragm. And we performed microwave ablation with the artificial ascites technique. CT a day after ablation showed the entire tumor necrosis. This slide shows the number of cases treated with radiofrequency ablation or microwave ablation at our institutions. We have performed more microwave ablation than radiofrequency ablation recently. Actually, this year, more than 95% of the cases were treated by microwave ablation. And the accumulated number of microwave ablation cases treated were reached 1,900 cases at present. Many high-volume centers of ablation in Japan have introduced new generation microwave ablation for liver tumors. And the combination of pharmacotherapy and ablation may build a new treatment strategy for advanced HCC, especially for large number of patients, of HCC patients. But today I don't have time to introduce the data. So now I'd like to talk about the Japan Academy of Tumor Ablation, JATA, which was established in January 2022 for the purpose of encouraging cooperation among members along with related institutions. JATA aims to achieve safe and effective performance of all types of ablation, including radiofrequency ablation, microwave ablation, and cryoablation, and others, in all areas of the body, including the lung, thyroid, kidney, adrenal gland, breast, bone, and soft tissues. And there are some triggers. Announcement of the result of SAF trial and the following revision of the treatment algorithm gave impetus to the establishment of JATA. And the Asian Conference on Tumor Ablation, ACTA 2021, in Tokyo also served as an impetus for the establishment. And expanded insurance coverage for ablation is the third impetus. And this slide shows the number of JATA members recently. So in Japan, the gastroenterologist or hepatologist mainly performs liver tumor ablation, and the 70% of their JATA members are gastroenterologists or hepatologists, and 70% radiologists, 5% surgeons, and 8% paramedics, business associates, and others. So Japan is the birthplace of ablation such as percutaneous ethanol injection and microwave ablation. So we continue to have the responsibility of leading the world in the field of ablation. In summary, as a result of the multi-center randomized control trial in Japan, SURF trial, and others, the recent treatment algorithm treats hepatic resection and ablation equally for patients with HCC of 3 or fewer tumors, each 3 centimeters or less in diameter. And Japan Academy of Tumor Ablation was established in Japan to accumulate clinical experience, research results, train future generations, and contribute to the future development of ablation. And our second general meeting will be held next February 10th at Okayama, and the president is Dr. Noso, and the deadline of the abstract submission is November 8th. This is the second prolongation. So this is the final deadline. So please send the abstract for the second Japan Academy of Tumor Ablation meeting. Okay, and we will hold the APASL 2024 Kyoto in Kyoto at the end of March 27th to 31st, and the deadline of the abstract submission will be. I will postpone the. We will postpone from the end of October to November 14th. So we would like to welcome all of you in Kyoto with cherry blossoms. Thank you very much.
Congratulations, Professor Shina, for your establishment of Japan Society. So I don't have any comments to this important presentation. I'd like to close this session. Thank you. Thank you very much.
Thank you very much, chairs and lecturers.